my name is Cynthia Peterson. I'm with Child Welfare Information Gateway. Information Gateway is the Children's Bureau's information service. And so I have the pleasure of being the out-of-home care and youth program manager there, where I focus on all of the website content, programs, and services related to out-of-home care and youth. So I am joined today by two of my colleagues, Athena Madison and Dr. Tom Mackey, and they're going to do just a brief introduction here so that we can all get to know each other before we get started.
Hello. Can you hear me? No. Can you hear me now? Okay. Good afternoon, everyone. I'm sorry for that. My name is Athena Madison, and I work for the Children's Bureau Capacity Building Center for the Art for the States, and I am a young adult consultant with them. I am here to speak a little bit about my story as it pertains to psych meds in the foster care system. There's going to be a time for Q&A for that, but we'll get into it. Thank you.
Hi there, and my name is Tom Mackey. I am recently joined the faculty at Rutgers University, and for the last several years I've been doing research around psychotropic medication oversight for children in foster care and for Medicaid-insured children more generally. And that research has sort of been in two areas. In one area, it's been very focused towards looking at the state of the states, so looking at what states are doing to provide for oversight for children who are in foster care, and then also looking at what is the comparative effectiveness of different state approaches for providing oversight for psychotropic medications? So what works best, essentially, and using Medicaid claims data to conduct those analyses. I also work with state systems. I've worked with the Commonwealth of Massachusetts, similar like Kentucky, a Commonwealth, and then also worked in New Mexico, Delaware, and now in New Jersey that I've arrived to Rutgers, located in New Jersey. So just beginning work with them as well. So it's really a pleasure to be here today, and I look forward to speaking to you more about this topic. So I'm going to quickly just go over the objectives for our talk today. Really, by the end of this presentation, we have a few things that we really want each of you to be walking out of the room having learned. And the first is to really learn to from and reflect on the experiences of Athena as someone who had an experience related to this topic within the child welfare system. There's a lot for us all to learn from listening to those who have been a part of the system, and we'll spend some time to do that today, and then we'll move to think more about what's happening nationally with regards to the psychotropic medication use among children in foster care. And we'll see that her experiences, although certainly unique, are not infrequent among the child welfare system. And I'll take you through some data that is our best understanding of rates of mental and behavioral health need among children in foster care, and then service utilization and specific psychotropic medication use. I've also incorporated some slides specific to Kentucky to help bring it back home for you. And then I'll also speak a bit about just what are the federal and state responses to psychotropic medication oversight. And then we're going to be highlighting a resource that recently was developed by the Children's Bureau and the Administration for Children and Families that provides a tool for youth themselves to be using who are in foster care around making decisions related to psychotropic medication use, as well as for their caregivers. Many of you in the room I know, and as a companion to that original guide. So Cynthia will be speaking to that for us this afternoon. So without further ado, although not on our program, only due to the fact that there were timing issues, we didn't have Athena join our panel until recently, so she didn't make it onto the program as a speaker with Cynthia and myself. I really think you'll probably learn more from her than you do from either of us. And so with no further ado, I'd love to have Athena share her story with us.
Hi, everyone. Can you hear me? My name is Athena Madison, and I am here to speak a bit about my story as it pertains to the foster care system, to experiencing mental health issues, and my experience with psychotropic meds. Not so long ago, and I really want to stress the importance of addressing mental health for foster youth. Not so long ago, me addressing those issues in myself was the fork in the road for whether I would succeed or become another statistic. And most foster youth, there's so much stigma behind it that never gets addressed. When I was 7 years old, my mom passed away. That was probably one of the biggest traumas in my childhood. But that wasn't the only one. There's so many back-to-back traumas that happened. And because she passed away, everything kind of spiraled out of control. When I turned 8 years old, I was in the system for the first time, and I had no idea what that meant. And I had to, it was kind of like being displaced constantly. And we had, there's so much chaos going on, I can't really say it all. But it was very unsettling. It was very disruptive. So we were on and off, and I got to a point in my life where I realized I was about 10, 12, and I realized I was going to end up dead or prostituted, and there was just no life there for me. And I really had dreams, and I wanted to be somebody, and I was the eldest of three, so I had my brother and my sister depending on me. And I decided to seek out the foster care system because I remember I'd been in it when I was 8 years old. And between the ages of 7 and 14, there's so much trauma that I developed something called hypervigilance, where I personally kind of shut off most of my emotions and only carried around fear and anger so that I could deal with my everyday life. And I didn't know this of me. It's just kind of my nature to survive. And at the same time, developing a lot of PTSD. And so when I finally found an entrance into the system at 14 and found a different version of permanency, that in itself was very traumatizing. It was like opening up a can of worms because for the first time I didn't have to be in this survival state anymore. And so everything came flooding out. The 6-7 years that I had been suppressing just kind of blew up in my face. And I didn't know what was going on. I didn't know why. And my foster parents didn't know what was going on with me. They kind of just, foster kids come that way. It's just kind of shoved off into that category. And I was too ashamed to speak up because I thought, what is wrong with me? I can't stop crying, and I don't know what and the hypervigilance, it's when your survival skills just don't turn off because your mind is so used to being in a survival situation that it doesn't know that you're no longer in danger. And so I was trying to get out of this mode, and I didn't know how. And when I entered the system, I had so many foster parents that just didn't understand what was going on. And I was so paranoid, and hearing like the jingle of keys, I thought my dad was coming, and I jumped right back into that mindset. And being pulled apart from my siblings, that was traumatizing. And so it was just this constant re-triggering. And I kind of had no help. I was kind of inside myself. And, foster parents are really conditioned to kind of put you in school, and you do this and you do that, and they're trying to regulate some kind of normalcy, but they kind of bypass the how are you? Are you okay? And so when I found some kind of stability, I realized I wasn't stable at all. It was more just me kind of regressing to shutting off a lot of the emotions because I just couldn't deal with them. And so when I graduated high school, I finally had time to kind of be me a little bit, and I realized I really need to heal, to like move on, because I just can't. And I noticed it was creating this huge block inside me to move forward. And so I reached out to a therapist. I figured, I have no answers, and I was getting to a point where I was going to do some very desperate things for kind of quick relief. And I kept kind of, I felt ashamed for myself, kind of pitied myself for even thinking that way. And my therapist, she was very open-minded, and I told her everything. She made me do something called trauma cognitive behavioral therapy, where she made me replay and retell my traumas over and over again until I was desensitized to them, till they no longer had that effect on me. And that was very, I can't explain it. It was amazing because it was so helpful, but it was some of the worst years ever. Just kind of constantly having to replay it. And I do therapy about 3 to 4 times a week for about 3 hours at a session, which normally it's more like once a week for 1 hour. And even though I was doing 3 to 4 times a week for about 3 hours, it still wasn't enough. And I'd come home to kind of decompressing, and it was never I could never turn it off. And my PTSD came back, and it kind of just got worse. And my therapist wanted me to find some kind of coping mechanisms to kind of deal with everything that was happening to me. And she suggested things like meditating and silent camps where you just kind of go for a week and don't talk. And just different things, just any kind of healthy outlet. And I found a lot of peace in painting. And so I'll show you some pictures later about some of the stuff that I did while I was going through that therapy. And painting was such a big, there's such a big result from that. It was just such a big deal to me because I could just turn my mind off and kind of just paint whatever came to my brain. I wouldn't even plan it. And then the painting turned out to always kind of have some kind of effect or tie to what I was doing in real life. And I just thought it was really kind of scary how even when I didn't want to think about it, I was kind of forced to. And so throughout this time, to this day, I'm 21, I still am doing therapy, not as often. So my therapist tells me, she's really proud of me. She says, we went from 3 to 4 times a week to one time a week every month, and it's just such a big leap. But yeah, and so if we could go to the next slide. So some of these paintings that are here are from my time in care when I just couldn't deal. The first painting up there, the skeleton, it was my way of kind of interpreting. I felt like my heart was being torn out of me, and I just didn't know where it would land. The elephant next to it, it was kind of like hoping, kind of some kind of release, but like a happy release. And the elephant is all dark and black and white, but everything that comes out is all color. I paint the anatomy a lot. I associate a lot of hurt with the human body. So down there, there's a part of me that it's like I'm just running. It's like this really deep need, and I remember just feeling like I just want to run away, and I just wanted to envision just really tall grass and like a meadow and just running freely, which is something that I think a lot of foster youth don't feel like they can do. They feel kind of trapped in their heads and in their situation, and even years after foster care, they're still kind of trapped because they never got to heal. The woman down there that's kind of shouldering away, that's just kind of a very literal response to like, I don't want to talk to you. I don't want to deal with this. I just want to not be here right now. Up there, the heart, it's bleeding gold. And it's kind of just, I think it's a way of me kind of giving myself more credit for everything I've been through, and kind of just finding some self-confidence in me. And then I love trees. I think they represent life, so I'm painting some trees. Down there, there's 4 paintings. There's one down here in the bottom corner, and it's just a couple kissing. And I think it was when I was about 16, and I couldn't associate myself to anybody in school. I was too traumatized, always being re-triggered by anything, by something somebody would say or where I would go. My campus was a very open campus. It's not gated when I went to high school, and so I felt like, oh my God, my dad could just walk in here at any moment. And so it's kind of this longing for normal, and I could see all the kids around me just dating and going through like that phase, that you do when you're growing up, and I just never had that. The girl right next to her, right there, yes, that one, it's a very interesting painting. It's a combination of interpreting both the emotional and mental and physical responses of feeling constantly re-traumatized. And I know you can't see so much detail because it's just so small in the picture, but her mouth is gagged. Her lungs are black, they're dark. There's a grenade in her stomach, so it's kind of just like the constant anxiety and always feeling like you're gonna throw up. Her limbs are broken, she can't help herself even if she wanted to. And there's a broken bulb in her brain that kind of just represents your mind shutting off. And always, you always want to kind of help yourself, but you can't, and you don't know how. And it's kind of like life is winning. The painting next to it, that kind of looks like Day of the Dead inspired, was a time when I was really sad, thinking about my mom. And she would paint a lot of Day of the Dead stuff. And so I thought, I should, I probably got painting from her anyway. So I thought I should paint something like that in her memory. And then there's a smaller kind of body painting down there. And you can't see the detail in this photograph, but her entire body is a tornado. And it's just kind of whirling. And the only thing you could see is like her beating heart. And I think it's just also just representing the chaos of it all. My experience with mental health, it wasn't like, I was very unstable, but I wasn't, it didn't show on the outside. I wasn't like violently acting and yelling at people. I kind of just break down and cry everywhere I went. When I was in therapy, my therapist suggested psych meds, and she suggested antidepressants and anxiety medication, and that was a horrible experience. I think she's really well-meaning, but I had every side effect you could possibly think of. I would sleep 16-hour days, and I fell asleep through all my freshman year in college, and I'd wake up in places I don't remember being in, and I feel like I lost gaps of time. I used to teach the independent living program classes to the Vashi locally, and I'd see how their staff members would come in and give them their daily dose of psych meds, and they would go from happy, bubbly, interactive students to zombies, and they just zone out. And I just thought, this is ridiculous. Like, it's like you're taking this person's youth away. You're not even letting them be a person. And so I was completely anti-psych meds. And when my therapist suggested, I was like, what? Are you kidding me? Like, no. But she, I was getting to a point where I couldn't keep swimming on my own. The therapy was way too much. But I kept going because I know I needed it. And I really wanted to just be normal or find some healing. So I did it. And I'm never doing that again. But it was horrible. I just, blacking out and not knowing where you wake up or why you're losing so much weight, it made me more depressed. I kind of felt more unguided, if that makes sense, or lost, because my therapist was trying to guide that situation and trying to help me through it with the therapy, but I felt more lost because I had so many spots out of my day missing. And I just remember just showing up to therapy almost every day of the week, coming home crying, trying to explain it to my foster parents who nobody understood. They just kind of knew things were really bad, but that was it. And then, it was just a very lonely experience. And the psych meds were just not the way to go. For me, it was definitely painting. But there's kind of a happy end to my story. I got adopted when I was 20 years old. I was the second case in California to get adopted under the new Assembly Bill 12 as a non-minor dependent. And, I have a lot of goals in my life. So I definitely don't want foster care to be a kind of identity that stops me from growing or becoming anybody in the future. I want to open a nonprofit that kind of caters to young artists, especially in foster care, where it's kind of like a museum of little art studios. I know that sounds weird, but I think it would be amazing to just walk through that and see kind of everybody's process. I want to write a few books. I'd like to write an anthology about foster care success stories and failures, because the failures, me being here today, I am considered a success story. So you hear all of my trauma and all the bad, but I am still here and I have succeeded. You don't hear about the kids that didn't, because they're not here, because they're homeless. And so I think that's very important, and it's not spoken about. And so I want to make an anthology about that. And then I am a political science and English major. And I love child welfare. I love advocating, and so policy is just definitely my heart. So thank you.
Athena, thank you. Thank you so much for sharing your story. Can you all hear me in the back? Okay, great. Thank you so much for sharing your story. So what we wanted to do was take an opportunity to see if you all had one or two questions of Athena. We just really want to try to take this time to answer any questions that you might have for her. So we want to open up the floor for that.
I just want to congratulate her.
We're gonna get the mic. So whenever you ask your question, if you can also just give us your name and where you're from, that would be great. Thank you.
My name is Brent Cottle, and I just want to say thank you for sharing what you shared, and congratulations. It's awesome to see that you found a niche in art, because I'm an artist as well, and I've expressed myself through art a lot through my life as well. So I don't know, I just kind of connected with you there. And I think it's awesome. I just want to let you know that.
Thank you.
Any other questions for Athena? While you all are kind of thinking about it, I actually have a question for you, Athena. So in terms of your experience with psychotropic medication and with the child welfare system, kind of thinking about support services and maybe something that might have been helpful on a systems level, have you kind of given any thought to what might have been helpful for you?
I think there's a lot of things that would have been helpful. If my foster parents were more aware and they knew what I was going through, I wouldn't have felt so alone. If I had been given an option, if my psychiatrist had actually gotten to know me, because he saw me once and he just kind of took my therapist report and said, okay, I think we're going to give you this. And it was just kind of a blind decision. And he was impacting my life in such a big way that I wouldn't even know how big. So I think that it was just kind of intrusive and disrespectful. And I know foster youth are rarely given a choice because people chalk them down as, you're damaged and you're young, so we know better. And I think I would have appreciated having a choice, having an opinion even, being considered, and then being able to say no if I didn't want to, if it got too bad, because I had to take them for a minimum of 6 months for it to have any effect on me. But the effects started within the first month. And I was like, are you kidding me? I have to do this for 5 more months? This is ridiculous. After a while, I started flushing the pills down the toilet because I just couldn't take it anymore. So yeah, having a choice, having a more in-depth conversation about what I would be experiencing, what that would look like in conjunction with therapy, and having more support, definitely.
Thank you, Athena.
Is it okay? That is on. Hi, I'm Kim. Congratulations too. I'm very proud of you. That is awesome. Thank you. We are foster parents as well. And did you seek out any help once you realized you didn't want to be on these medications? How did you finally get somebody to listen to you to get off of them?
It's funny, as my therapist and I are really close, and so even though she was really close to me and she would have been the person I would tell that I wanted to stop, I was so afraid to tell her that because she kept thinking, you're doing so well and blah, blah, blah. And I was like, I really don't want to disappoint you, but I'm crumbling inside. So I just stopped taking the medication and didn't tell her. And my foster parents were not invested. I was always a very independent kid. I was 15, but I had my microwave, my fridge, and my own laptop in my bedroom that I had to pay for myself. And they just kind of knew I was handling my business, so they were never involved in my life. And that also included therapy. So at the end of the day, I just say, oh, hey, hi, I'm good, okay, great. And that was our relationship. So I stopped taking the medication. And then my therapist, she said, you're doing really good with the medicine, right? And I was like, actually, I stopped taking it a while ago. And so that was really what happened.
My name is Mandy Roberts. I work with foster parents. I do training. And I'm just curious, is there something that foster parent could have done that would have helped you connect with them to feel comfortable enough. That's my foster parents struggle sometimes. What can I do? They want to do something, but they're not therapists. They're not doctors. But it's hard. They want to know, what can we do? And I would like to be able to take at least part of your story back and talk to my foster parents to let them know there is something they can do.
Yeah. For me, and I know for most foster youth, like a lot of foster youth are really conditioned, and they condition themselves to not talk about their emotions because you're already stigmatized as broken and damaged. And so at the end of the day, most foster youth just want to connect. They want love in their lives. I think that's basically what it comes down to. And when I was first going through that therapy, my foster mom, the first thing I told her was, when I met her, was, I don't love people. Don't expect me to love you. I won't say it. And that's it. And she was like, whoa, okay. And I think from that day, she made it her mission to change my ideas on that. And she was the first person I said, I love you to. And so it was a really heavy relationship to be going through and experiencing for the first time what a mother's love feels like, and doing PTSD therapy. It was really heavy. And I think maintaining that connection, because even though she had no idea what was going on in my therapy, she made it a point to say, I love you every day, to hug me, even though I did not want to. I was so desensitized to touch, to human touch. I mentioned how I had to shut my emotions off for a long time. That included physical touch, any kind of love, anything. And she kind of forced me to get back into that. And she'd just hug me, and I'd just freeze there like, what are you doing to me right now? And it was so uncomfortable. It was so foreign. And I think, I'm not the only case that is like that. There's a lot of foster youth that are like that, and it freaks them out. And they'll just push you away. They'll find ways. They'll make themselves unattractive to you, so that you don't want them. People do that all the time. I do that all the time,
Thank you. And so, Athena, in terms of your foster care placements, you had a total of 13 placements.
Yeah.
So that in itself, as we know, as supportive adults and service caseworkers, that a lot of times that does affect our young people's ability to really connect on that level. And really for foster parents, part of the workshop that you all are sitting into today is going to give you some resources as caregivers and supportive adults that can really kind of help walk through some of those questions and walk through some tips and strategies for having those conversations and better connecting with young people in terms of their mental health and psychotropic medication use.
Yes, my name is David, and again, I want to thank you as well for telling your story.
Thank you.
I'm just curious, since I don't know how long you've been telling your story for, but since you've came out with a story about the psychotropic medications and things, what's the response been like from the mental health field or other people you've engaged with? Because it seems to be, as social workers and foster parents don't want kids to be on some of these medications, we get kind of shut down at times. There's that doctor you were speaking of who sees his kid once every 3 months for medication management overrides everybody else. I have a problem with that. What kind of response have you got since you've told your story about not wanting these meds because of how it made you feel?
I've come into contact with a lot of foster parents and caregivers and social workers who feel the same way, who want to speak up for the youth and feel like they can't. And I remember when I was teaching the ILP classes, there was a few youth that had similar problems that they felt they themselves didn't have a voice. And but when they started this is going to sound so terrible, but what I did, for example, and they started doing the same, was, you know what, I'm going to talk to your boss. I really don't want this, and you're treating my life like it's chess. Like, I'm going to tell me what your boss's name is. And there's this kind of fear, and it's funny because it's their life you're interrupting, not your own. And so I don't understand what the kind of pushback is. But I know that in the situations that I've seen with the youth I've worked with, it was always successful when they themselves kind of stood up for themselves and really just kind of found their voice and were like, no, I don't want this. I don't need it. I will take other modes to heal and cope if you will let me and guide me through that, and by all means, and people have done that, and it does work. I think because it's uncomfortable and it's different, and the doctors don't expect that, so it's very like, okay, sure.
And we're going to go ahead and take one more question. And just so that you all know, if you don't have an opportunity to ask your question now, we're going to go ahead and move through the rest of the workshop, and then we'll have another Q&A section at the end. So if you can jot down your question if you didn't get to it, please know that you'll have an opportunity to do that towards the end of the session.
I don't really have a question. I just want to give encouragement. My name's Ian. I spent 13 years in the foster care system as well. And so I just want to appreciate you sharing your story, and you doing the advocacy you're doing, and the political major you said, and all that stuff. And I appreciate you connecting with the people you connected with, and keep doing this work. And I'm doing the same work. And so just know you're not alone out there, which you seem like you already know that. But just encouraging you even more that, there's other people that are fighting with you, and, fighting a good fight. And just in terms of just knowing that we exist, and, we're trying to, get better and be success stories instead of statistics. So
thank you.
Yeah, thank you. Okay, great. So what I'm going to do is go ahead and turn things back over to Dr. Tom Mackey, who's going to go through Objectives 2 and Objectives 3 with us. So we're going to go ahead and get him mic'd up so that he can, so you all can hear him when he speaks.
Go ahead. Great. So I think I may have accidentally misspoken and said you may learn more from Athena than you will from us, and I can say that you will learn more from her. Thank you so much for sharing your remarks, and we really this topic takes on new significance when you hear how it affects those that are a part of the system, and so I'm really grateful for that opportunity just to start our talk and our conversation with you today with such a significant experience. And what I'd like to do now is sort of take you out of the experience of one person and into sort of what does the national landscape look like, and how common are concerns around the mental and behavioral health needs of children in foster care, and then in service utilization in particular around psychotropic medication use. How frequently are people being prescribed medications in ways that may not be consonant with what best practice is or understood to be? And particularly children in foster care, of course. And that the slides that I'm presenting now, just to say, are reflective of a collaboration that I've had over several years now with a child and adolescent psychiatrist, Dr. Chris Belanci at Tufts Medical Center, as well as Laurel Leslie, a child and behavioral developmental pediatrician at Tufts as well, and also Justine Hyde, who's at the Institute for Community Health, a Harvard affiliate. And the research and the work that we've been doing together has been funded by a number of different organizations. I'm obliged to let you know of them. The Agency for Healthcare Research and Quality, W.T. Grant Foundation, and Charles Hood Foundation. And just when I'm presenting today, I don't have any conflicts. I'm not being supported by any drug companies, for example. So I have no conflicts to disclose. Again, something I need to say. So when we talk about mental health needs of youth in foster care, we really are talking about a population that are disproportionate risk for a mental and behavioral health condition. And for a number of the reasons that we heard Athena mentioning earlier in terms of just the trauma that they've been exposed to, the adverse childhood experience, as many refer to, that lead to the presentation of emotional and behavioral conditions and the ultimate disorder being diagnosed. And so when we look at claims data that around diagnostic of emotional and behavioral conditions, we find that a general point prevalence rate in the community of 50 to 80% among children and youth who are in the foster care system. And you can see that differs quite considerably from the community-based rate of 11 to 25%. It's significantly higher. And there also are multiple factors that are contributing, as I'm sure you're all very aware. I was just at a session on child trauma and brain development, and so I don't know if any of you were at that session as well, but they spent a lot more time talking about the reasons underneath why you might see this emotional and behavioral disorders among the subpopulation at such high rates. But they relate to the abuse, the neglect, domestic violence, the poverty that is endemic to many of these families that are involved with the child welfare system, disproportionately likely to be living in poverty. And also the in utero and environmental drug exposures that might have occurred prior to birth, of course. And lastly, genetic loading, that there is some emerging evidence around the possibility of children who are in the foster care being disproportionately likely to have parents who have mental health conditions, and therefore being more likely themselves to have them within the system. I just, having coming from that last plenary session, they spoke to the ACEs study, or the Adverse Childhood Experience study. And in that session, they did a better job than I will today, given that this isn't the focus of our talk. But they spoke about the potential consequences of toxic stress in early development, and that this really does lead to a pathogenesis for adult disorders, both physical and mental health conditions. And that there is increasing evidence that these adverse childhood experiences lend themselves to a series of high-risk health behaviors that then lend themselves to a series of physical and mental health conditions, and to early death at the end of the day. And for every adverse childhood experience that a child has, there are disproportionate risks for, or there are predictors for less years of living, higher mortality rate. And lastly, there are sort of growing documentations. Jack Shonkoff writes about this in his work on Neurons to Neighborhood, of how living in environments that expose to toxic stress, how living in these environments have neurological effects and have neurological disruptions to the young child, and then that has a lifelong consequence in their development that can, with considerable, it's not a determinant, but it's a predictor of these later conditions, as our plenary speaker said this morning, and referring to the same study. And so this is really a whole life perspective that looks at how adverse childhood experiences lead to this disproportionate risk for neurological disruptions, and therefore social, emotional, and cognitive impairment. And these impairments then lead to the adoption of health risk behaviors, disease, disability, social problems, and then the early death. And just to say that when we look at those children who are in the foster care system, there are longitudinal studies that have looked at what are the outcomes down the road for this subpopulation in particular, and they're less favorable, as you may not be surprised to hear, that lifetime prevalence of those with mental health disorders who experienced stays in foster care were actually considerably worse than their peers that didn't have those stays. And for those that are alumni of the foster care system, 30% will have, in adulthood, will have PTSD, while only 7.6% of the general population. Major depression will be 41% of those who had to stay in foster care, as opposed to 21% in the general population. This is any time in adulthood, right? It's just any time. A panic disorder, 21% versus 4. That's a five-fold rate for children with stays in foster care. General anxiety disorder, almost a threefold rate of 20% for those with a stay in foster care, as opposed to 7% in the general population. And drug dependence, almost 5 times the rate, at 21% of children with a stay in foster care, as opposed to 4.5% of the general population. So those are some startling numbers around what happens later, when children have left the system and come into adulthood, and the need to be having delivery systems while they're in foster care that anticipate the long-term consequences of the trauma that they've experienced, both prior to and then while in the system. And so there has been, as I'm sure many of you are aware, an exponential increase in the use of psychotropic medications for emotional and behavioral disorders in children across all populations, across the general population, the Medicaid-insured population, and children in foster care. And this is particularly true of those that are very young children, so preschoolers especially. And this raises some concerns for us because there are evidence gaps around what we know on the long-term safety and efficacies of many of these medications. So on the one hand, we know that many children need these medications to succeed, but we lack a lot of evidence about what these long-term consequences are for these medications. So it requires additional effort to provide ongoing monitoring and to ensure that these long-term consequences aren't the unintended ones and the potential side effects that may arise from the use of these medications. And so this is some work that came out of the Reach Institute, headed by Peter Jensen and his colleagues. And they did a systematic evidence review looking at the evidence that was available for a variety of different medications. And you can find this online. Feel free to look. You can look on our Reach Institute, and it comes up almost right away. And you'll see, I'm going to give one example, but they assessed the evidence to determine what was known about the short and long-term safety and efficacy of psychotropic medications, and they gave different labeling to these medications, the assessment of the evidence available. And if it received an A, it meant that it had adequate data to inform the prescribing practice. If it received a B, it meant there was some data to inform prescribing practices. And if it received a C, it meant there was no controlled evidence or negative studies, and that it had received case report and then FDA reports of adverse events, but not a rigorous standard in any methodological, not according to our standards in research. And just as an example of one evidence gap of this report, I could spend an entire hour telling you about all the evidence gaps that exist, but I want to give you one example and encourage you to look at a resource like this in the context of the families that you're working with, to become more informed about where the evidence gaps are and to ask those questions that Athena was saying earlier are so important to ask when decisions are being made to use psychotropic medications. And in this case, they looked at a specific series of symptoms and then what medications are being prescribed and then the evidence available. And so this is aggressive conduct, and then they were specifically looking at the class of antipsychotics, atypical antipsychotic medications. And what they found is there was adequate data available to inform the short-term efficacy and safety of these atypical antipsychotics for aggressive conduct. This could be a mixed evidence base, right? It could be both positive or negative, but that there is evidence there to inform it. Meanwhile, there's limited or no evidence available to inform the long-term efficacy and safety of these atypical antipsychotics, right? Which means asking more questions makes a lot of sense, right? That the informed consent process has a higher threshold in the context of that clinical visit because there's less evidence about the long-term efficacy and safety of these medications. And so that has led to recommendations, for example, with these atypical antipsychotics, that they always be used concurrently with psychosocial therapies. So with trauma-informed psychosocial therapies, so that you're not using the medications without having had some other therapy offered at the same time. It's also led to the recommendation that there be cardiometabolic monitoring when prescribing atypical antipsychotics. So if a child, for example, in your care is receiving these atypical antipsychotics, they should also be receiving cardiometabolic side effect monitoring over time to ensure that there aren't those unintended consequences associated. So this is just one example of the evidence gap that exists within the context of thinking of these medications that sort of warrant the additional attention to this within the context of medical treatment. And in 2005, there are significant amounts of there's a policy interest in this because there's a lot of money being spent, right? This is not an inexpensive endeavor. And so I'm going to speak more broadly about the Medicaid-insured children, the big bucket, and then I'll talk about children in foster care specifically. And so in 2005, there were 2.8 million Medicaid-insured children who used behavioral health care. And of those, 1.7 million use psychotropic medications. That's a fairly notable percentage or total number. And although only 10% of Medicaid-insured children use behavioral health services, about 2.7 million, these services account for 38% of the expenditures, right? So you have this will be a theme in these slides. You have a small population that are really using a large number of the resources, and this is certainly true of children in foster care, as I'll speak in a moment. So children in Medicaid from racial and ethnic diverse backgrounds are less likely than white children to receive behavioral health services when they're Medicaid insured. So this may not surprise you, it may. While white children account for 39% of Medicaid enrollees, they are 52% of the behavioral health service users. right? And then you look specifically at that while Black or African American children account for 26% of Medicaid enrollees, there are 25% of the behavioral health service users. So you can see some disproportionate using of the system, right? Which would, you're in positions, many of you, to make sure that those numbers don't continue, right? That we get all kids that need services into the system, and that we rectify some of these disparities that do exist. And that adolescents aged 13 to 18, while they represent 25% of the overall Medicaid child population, they're 45% of the children that are using behavioral health services, and almost 60% of the expenditures in behavioral health systems. That's not too surprising because of where presentation happens for mental health. But it's worth noting that adolescence is characterized by increased use of our system, and many of our dollars are being spent in those age groups. Children in foster care, this is another slide that shows you that while only 3% of those that are Medicaid insured, children in foster care, they account for 15% of the service use and 29% of the expenses, right? So if you're thinking of the population, it's 3%. If you're thinking of the service use, it's 15%, but then the expenditures is almost 30% of total Medicaid dollars for behavioral health services. So again, small population. So we often use the shorthand we say is 3% of the population, 30% of the expenditures, right? That's maybe a number to kind of keep in your head. And that's not a bad thing, right? But it means that making sure those services are being provided in the appropriate way and in the optimal way, that we're getting the most for our money, is really important, right? And then children in foster care are frequently prescribed psychotropic medications, but only half those getting psychotropic medications are receiving accompanying behavioral health services. So unfortunately, I think many of you probably, I don't know specifically of your experiences in Kentucky, but I can say nationally that reimbursement rates for the behavioral health services, for the psychosocial therapies that often are the recommendation alongside the use of the psychotropic medication, are frequently underfunded, under-resourced. There are shortages in terms of people who are trained in those therapies. And so the medications become an unfortunate replacement for even what would be clinically understood to be best practice. So I want to really speak specifically here about rates of antipsychotics. This is a national study that was conducted by David Rubin and colleagues at the Children's Hospital of Philadelphia in 2012. And what they find is that the rates of antipsychotic use nationally were at 8.9% for children who were in foster care. They use Medicaid claims data, so it's a very good data set to get this kind of figure from. And they found that it increased over time from 2.9% or 8.9% in 2002 to 11.8% in 2007. So there was a significant increase when they controlled for a number of other factors as a time trend in the rates of antipsychotic use for children in foster care. And it is the fastest growing class of psychiatric medications. This has led to significant policy attention to the use of this class in particular. And Medicaid enrolled children aged 3 to 18 grew 62%, across all the states that were included in this data set from 2002 to 2007. And lastly, ADHD is the most common diagnosis for antipsychotic use, which is interesting and not what many would expect. But it's often the aggressive presentations of ADHD that will warrant the use of the antipsychotic. And then you can see it's bipolar and then ADHD and bipolar concomitantly. And the trajectories of second-generation antipsychotic use here in Kentucky, right? So their study is great because you can actually look at state estimates. And so I pulled this from that same study that I mentioned, David Rubin and colleagues at CHOP. And here in Kentucky, you had 15% prescribed in 2002 of children in foster care, according to their data set. And then you can see as you're moving across time, in 2003 there was an increase, in 2004 there was an increase. These are statistically significant. In 2005 it was a decrease, and then it maintained the same in 2006 and 7, and then in 7 you ended up at 18.2%. So while it only increased in 2 years and it stayed the same in 2 years, there still was an 18.7% increase just between 2002 and 2007. And so there's increasing concern around this escalating rate, and these are your local numbers. And then there's also concern, in addition to antipsychotic use, around the use of multiple medications at the same time. So concomitant therapy is what we'll often call it, or polypharmacy. And so children in foster care who are prescribed psychotropic medications are more likely than other children in other age categories to receive multiple of them at the same time. And this is particularly surprising. It might not be surprising for Medicaid insured generally, but for SSI, where disability is required for entry into the system, it's particularly surprising that children in foster care have been seen to have higher rates than children who are SSI insured through Medicaid. Because of the eligibility criteria, there's a selection bias for that. So that has been particularly sort of surprising to the field as we found that out looking at these claims databases. And then also among children in foster care prescribed psychotropic medications, 49% have been found to be prescribed 2 or more medications at the same time, and then close to 20% prescribed 3 or more medications. Again, raising safety concerns around whether this is really best practice for a particular case. And it can be in specific circumstances, but it really requires an extra set of eyes to ensure that that is compliant with our best understandings. There are also particular concerns around co-pharmacy, or the use of 2 or more antipsychotics at the same time, or other medications. So here we have the trajectory of polypharmacy here in Kentucky from the same study that I had mentioned earlier. And if you follow me here, it was 8.5% in 2002, and it rose statistically significantly in 2003. It remained non-significant, so it was about the same in 2004. Significantly less, and then the same in 2006, 2007 to 8.6%. So here, you're not seeing the same growth in polypharmacy here in Kentucky. But I wanted to still tell a story because it's good to know what's happening in your own state, particularly among such a vulnerable population where the needs are attenuated. And so now I'm going to spend my last few slides just summarizing the recent federal and media responses to these concerns. And I will refer you. Do we have handouts?
Yes, on that.
Okay, so on the jump drive, there's a handout that has a series of different resources that are available to you, and that includes some Government Accountability Office links to Government Accountability Office reports. So the Government Accountability Office, or the GAO, in DC, has conducted a series of investigations looking at psychotropic medication oversight for children in foster care, and these reports have led them to make a call for the federal government to take more action around oversight of psychotropic medications for children in foster care. And those reports, there's also some congressional reports that you'll find on that resource sheet, have led to policies like Fostering Connections, which is a 2008 policy that hopefully many of you are aware of. It had a series of ripple effects for child welfare agencies across the country in education, but also in health and oversight of health. And so it required that states develop a plan for the ongoing oversight of health services for children in foster care. And what I will particularly point out is that it also required for collaborations to occur in the context of creating these plans, so that state agencies collaborated with their Medicaid agency, as well as with youth with lived experience in the foster care system, and with pediatricians and other prescribing clinicians for these psychotropic medications. So there was also a mandate for states to involve people that were affected by the kinds of reforms they might make in response. And then it wasn't until 2012 that we got a real sense for what the interest was around these plans. The plans originally were more broad around health and behavioral health. And then in 2012, the plan that needed to be submitted as part of the health and service coordination plans to the federal government included protocols for the appropriate use and monitoring of psychotropic medications. So now what we've seen is that there's a sort of series of state responses to this federal mandate, and the fact that funding relies on fulfilling the statute, this requirement for a protocol, a health and service coordination plan. And so there's a lot of movement happening now. So it's a really particularly good time to keep on top of what's happening here in Kentucky, because many states, including Kentucky, I've learned, are making policy responses in response to these federal mandates. And so just to say that this piece of the puzzle, this idea that the Government Accountability Office has found that there might be insufficient state oversight and monitoring of psychotropic medication use, is only part of the cause, right? So just to be very explicit about the fact that there are multiple factors that are, we haven't yet from research been able to disentangle all of this, right? You can imagine that's virtually impossible because it's multifactorial in nature, I would argue. But there also are gaps in coordination and continuity. As Athena told her story about the number of different placements that she had over the course of her time in child welfare, unfortunately, that's not an uncommon experience in many child welfare systems. And there also are so many different types of service systems within which one child is interacting. So one child might have multiple caseworkers, they might have be engaged in the educational system, a mental health provider, a primary care provider, and then have specialty providers that they're seeing alongside that. And all those individuals, right, are trying to coordinate services alongside the biological family, still wanting, in some cases, to be a part of the process and needing to be part of that process. And so you just have this really complicated set of coordinating multiple, very different types of stakeholders in that child's health and well-being. And that can create gaps in coordination, as I'm sure you've all experienced if you're doing this hard work. There also are provider shortages, and particularly provider shortages in board-certified child and adolescent psychiatrists. That particularly is true in more rural areas, which I know characterizes some of Kentucky. And then there also are shortages in those that are trained to provide these psychosocial therapies that offer alternatives, right? So there can be significant shortages in particular regions of the country with regard to licensed individuals to offer trauma-informed cognitive behavioral therapy or parent interaction therapy, any number of possibilities. And there's also a lack of access to effective non-pharmacological treatments. And this also, I'll just say, also connects a little bit to how we reimburse within our Medicaid systems, right? So there's also, unfortunately, there's not enough payment coming into those services oftentimes in the public insurance schemes. So the responses here in Kentucky, well, we did a little bit of legwork to present to you today and spoke with folks that were in your state agency here, your child welfare agency. And we learned that there's a pilot program now called Safe Spaces, and that they're providing trauma-informed screening and mental health assessments, and that this is also sort of a service coordinate, like it's case planning alongside being trauma-informed screening and mental health assessment. And this is a big part of the puzzle, right? Is making sure that when they come into the system, there is a trauma-informed approach to identifying what the mental health needs are, so that labels aren't getting put to a child that don't apply given the history of abuse and neglect that they may have experienced prior to arriving into the system. And so certainly that type of front-end diagnostic work is critical then to determining what an appropriate treatment plan looks like going forward, right? So, and we found that many states are implementing this type of approach of being more trauma-informed in the way they identify the mental health needs of children who are in foster care specifically. This is also a training concern because it's difficult to find clinicians that actually have that background and that specific attention to trauma-informed mental health care. And it's not every clinician that has that kind of experience and background. So having a program like Project Safe Space is a wonderful way to begin to build the capacity of your service delivery system for that type of approach, trauma-informed, of course. And there also is a prior authorization program. At least last we had heard, things change fast in state policies, we know. But for antipsychotics, atypical antipsychotics in particular, there's a prior authorization program we understand within the Medicaid plan. Does everyone know what a prior authorization program is? So when a physician ends up wanting to prescribe an atypical antipsychotic, they will need to submit a medical necessity form frequently, like that's what they call it, but that it substantiates the reasoning clinically for the use of that atypical antipsychotic. And different prior authorization programs require review from different people, but frequently it's a peer, it's another prescribing clinician or it's a PhD level pharmacist that might review that medical necessity form and ascertain whether or not it's an appropriate prescription given the described presentation and symptomology. And that's issued by the Medicaid program, by the public insurance system. And then here in Kentucky, we also learned that you have consultations through Service Region Clinical Associates, or SRCAs, available. And that while they vary region from region, we were told in terms of the kinds of consultations that they offer, we were told that they, within their scope, would be offering mental health consultations to support case management services. And lastly, there are case reviews. These are the 6-month case reviews that occur that should also be a review of the medications being prescribed to a child in foster care, the psychotropic medications specifically. So these were some of the mechanisms that we had heard were in play here in Kentucky. And during the Q&A, we can spend more time thinking and talking about what other states are doing, but we thought it would be worthwhile to spend a little bit of time speaking about what's happening here as best we can learn. So now I'm going to hand it out to Cynthia, who's going to give you like a real concrete tool he's going to talk to you about a real concrete tool that's available and that's on your jump drive. So I'll hand it over to Cynthia.
Thank you, Tom. Okay, with the few minutes that we have left today, what I'm going to be doing is kind of walking you through a couple of the different tools that would be really helpful to really bring the presentation together. So in terms of dealing with youth and their real life circumstances, and also all of the information that we've learned from Dr. Tom Mackey just in terms of what we know about psychotropic medication in youth and foster care. So what we have are resources, and they are guides that have been developed by the Children's Bureau. One is Making Healthy Choices, a guide on psychotropic medications for youth and foster care. And that's the original guide that Dr. Mackey was just referring to. It was developed in 2012. And then the most recent one is Supporting Youth in Foster Care, Making Healthy Choices, a guide for caregivers, caseworkers on trauma treatment and psychotropic medications. So I'm going to spend a little bit of time talking about both of them. I'm going to briefly talk about the Making Healthy Choices one, the first one, and spend a little bit more time talking about the Supporting Youth in Foster Care and Making Healthy Choices. We'll spend a little bit more time on that one. So in terms of the Making Healthy Choices guide, the 2012 version of this was really focused to help youth in foster care understand and make decisions about their mental health care. And so the Children's Bureau got together and really kind of wanted to better support the federal mandates that were coming down, and really wanted to give youth a tool that they could use themselves to really be able to make some informed decisions about their mental health care. So the guide has been a tool for youth to use. It has a lot of valuable information in it. What it really does is help youth to be able to recognize when they need help. It helps them to consider the treatment options that may be available to them, what questions they might ask along the way, and then also talks to them about taking medication safely. So kind of the situation that Athena was in, where she really didn't want to talk to her therapist about ending her medication or really the severity of what she was going through, but really being able to help youth kind of think through some of those things for themselves and really advocate in terms of taking their medication safely. One of the nice things about the Making Healthy Choices guide is that it does have a checklist in there. And so the youth can actually go through the checklist themselves and ask themselves some questions. And it really kind of helps them kind of think through where they're at, or what questions that they might want to ask of their supportive adult or their mental health or healthcare provider. So kind of moving into the evolution of the 2015 guide, what the Children's Bureau really wanted to do was to basically come up with a companion, something that, recognizing that giving youth a tool is one thing, but 9 times out of 10, that youth is working with a case manager, a foster family. They have a lot of people in their lives who are supporting them. So the Children's Bureau really wanted to take the opportunity to look at, well, what can we do that would complement the youth guide? And so that's where the 2015 guide comes in. And that really is to help ensure that caseworkers, foster parents, relatives, and other supportive adults that care about youth and foster care have some guidance to help them support the youth's treatment needs. And so that's one of the most important things that we've kind of talked about today, with Athena, going through her journey and how she really felt like if she had a little bit more support from the people in her life, that her experience might have been a little bit different. So the guide was developed through a collaborative committee of many youth and also professionals. So if you're interested in who all was involved in that partnership, you're welcome to take a look at the end of the guide. It tells you all the different people who were involved, all the different agencies. It was field tested, so we did surveys to get feedback on what was working, getting suggestions from caregivers and relatives, from caseworkers and supervisors, just in terms of what, if we had, had a tool for you, we had a resource guide for you, what would that look like? And being able to incorporate all that into the guide. We always like to try to make sure that we have youth input. We really don't want to put anything out that doesn't, that's about youth, that doesn't involve youth in the process. And so youth who have been in foster care did provide their feedback. And so like Athena being here today, we made sure that they were incorporated. We got their suggestions. And not only that, but we also they also wrote a section that is in the beginning of the guide that really speaks to things that they would love to be able to tell their caregiver, relative, or their case manager about their medication use or their mental health needs. So it's really a message that kind of says, just don't take, oh yeah, I'm doing good as an answer. Here are some other things that you might want to think about asking to get more information from me. Instead of just being like, oh, well, your appointment's on Thursday at 12 noon. Okay. Making sure that the foster parent asks maybe, are you comfortable with me going to that appointment with you? And if not, being able to maybe talk through what might be expected during that appointment so that you can be prepared to ask questions or those type of things for the appointment. So the guide is designed to help caregivers and supportive adults learn more about trauma treatment for youth in foster care, and especially for those who want to work towards improving their mental health. So the Making Healthy Choices guide is really focused on trauma and really bringing in that trauma-informed piece. And chapter 1 covers how caregivers and supportive adults can use the Making Healthy Choices, the first original guide. So if you're not familiar with that and you're like, oh, I really want to use it as a tool with my young person, it gives you step-by-step of some different strategies that you can use the youth guide to encourage the youth to use that as a tool for themselves. Chapters 2 and 3 of the Making Healthy Choices guide really, like I said, helps adults understand the trauma and treatments for trauma. And so like Athena was saying, one of the things that would have really helped her is if the folks in her life would have been a little bit more informed about what might have been going on with her and why. So it provides a really good background information on trauma. It also offers suggestions and additional resources on how to promote and build resilience for youth who have experienced trauma. So that's a really, really great piece to have, is to be able to have those suggestions and additional resources like what you were saying, like how do I have this conversation? How do I even begin? How do I break the ice here? And it also describes different treatments that can be used to help youth heal from trauma and what possible role medication may have in helping the youth control their symptoms and function better. And like we talked about, that's so important to not just have a one-size-fits-all approach. That with psychotropic medication especially, you want to make sure that your young people, the people that you're working with, your young adults really have an idea of what the options might be, and that it may not necessarily always be traditional therapy, but like for Athena, it was artwork. For someone else, it might be yoga. For someone else, it could be, a regular, being on a sports team that really helps to build some of those resiliencies and help them move forward. So one of the things that I missed that I want to make sure that I let you guys know is that the youth guide is really written for adolescents, for teenagers, and then also young adults. So that's the age range that the guide covers. And it's also available in English and Spanish. And so I'll tell you a little bit later about how you can access that. So chapters 4 and 5 offer strategies for helping youth. And that's like so important, like I said, to get some of those ideas. Tips for recognizing and addressing youth needs. Like sometimes you're working with a young person and you're thinking to yourself, something just isn't about right. I'm a little concerned, but I'm not quite sure. But this really walks you through. And I think a lot of the questions help to either affirm that, yes, I really do need to have this serious conversation with my youth and make sure that they're okay and let them know that this is why I'm concerned. And the other thing that it walks you through is how to get a professional assessment and evaluation, which is really so very important. If you're having that conversation with your young person, you want to be able to help them make the next step, to kind of talk to them about, okay, well, I have, where you have this concern or we have this concern together, here is the next step. We want to make sure that we get an assessment because what I think might be one thing, but we want to get a professional's opinion about this as well. So one of the key things is I think most of you all know in this room is that it takes forever to get these appointments. So you could wait 6 months or longer to get on someone's docket to get an appointment. So the guide really helps for you to be thinking about what information should you be providing or what questions that you might ask, because you want for that probably 45 minutes to an hour that you're sitting down with that care provider, you want to make sure that, for one, that your young person has everything that he or she needs for that appointment, because that could be the worst thing in the world for them to show up and not be prepared and then have to maybe make an appointment for 6 months down the line because they didn't bring an important form or they're not making a journal in regards to their symptoms and behaviors that might be helpful for that appointment. And you also want to kind of go with your kind of interview questions, right? In terms of making sure that this is the doctor, making sure that your young person feels like this is the doctor that they can connect with, that they'll be able to trust, and also has their best interests. So not just showing up and just taking that prescription and walking out the door, but really having a conversation with the healthcare provider to say, here's some questions that we have. What type of treatment plan would you, suggest, based upon, X, Y, and Z, those type of conversations. Which moves into the next point, which is about information about effective treatment and transition planning. Anytime that you're working or have your young person is working with a healthcare provider, being able to have a treatment plan. There never should be, something just kind of prescribed without having a plan. How many of us take medication, right? And you want to make sure, and especially after what Dr. Mackey has shared, that if we don't have any long-term results of how this is affecting our young person's body, we want to make sure that this is not an indefinite situation, right? Most of us, when we go to the doctor, we're like, okay, well, how long am I going to need to be on this medication? Is it lifelong? And if so, how is this going to affect my body? And so we know that we don't have a lot of those answers in terms of the long-term effect. So we definitely need to be having conversations about what does this treatment plan look like? What is most optimal? If this young person has to be on medication, what other things could they be also doing to kind of help with the recovery? And making sure that, when you're having those conversations with that mental health provider, that they're giving you the type of answers that you're saying, yes, this is the person that I want to work with, because I know that they're not going to just put a young person on prescription medication and kind of forget about them. And so having that transition plan in place is good from the very beginning. What milestones are we going to be expecting to see so that we know that we're working in the right direction? Which moves into what changes to watch for and how to support progress over time. So say, for instance, you all have this treatment plan, it's all laid out, and then all of a sudden, like Athena was saying, a month later, she's got all kind of side effects that, well, we figured it might be 1%, and your young person happens to be that 1%. Well, what do we do about that? Do we go back? Do we, decrease this or whatever? But those are conversations that you have with your you encourage your young person to have with their behavioral health professional, because no one should feel like that they are just forced to take something and have to live with side effects without really kind of talking through what the alternatives may be, or alerting someone that these things are going on for them. Okay, so that covers the guide, and so what I want to do is make sure that you all know how to access the guide. It's available from the Child Welfare Information Gateway website, and you can access that at www.childwelfare.gov/pub/mhc-caregivers /. And there's a limited number of hard copies that are available. So if you need multiple copies for training, you want to share it forward, you can actually get in contact with the Information Gateway support staff, and you can call them at 800-394-3366 or email them at info@childwelfare.gov. And again, the guide is available in English and Spanish. And what's really nice is that on the thumb drives that you all have a copy of it. It's also available on the conference website. So I'm hoping that the thumb drives that you guys have, you will share that forward and pass it along to someone else as well. Okay, and so for more resources, you can visit Information Gateway's webpage on the use of psychotropic medication and trauma-informed practice. So I really think between those two web sections, you'll get everything that you need. You can search use of psychotropic medication in the search box, and what that's going to do is going to bring up that particular web page. It has not only the guides on there, but it also has information about all the legislation that we kind of talked about. It talks about any guidelines. It also provides links to what other states might be doing, along with other reports on this topic, including the report that Dr. Mackey, the study that him and his colleagues did that he talked about earlier. And then our trauma-informed practice session is really, really strong in terms of really being able to kind of think about this more holistically in terms of how do we move our child welfare practice to a more trauma-sensitive way of working with children and families. So at this point, I tried to pack this all in because I wanted to make sure that we had time for questions. And so we've got about 10 minutes to answer any questions that you all might have. So I'm going to go ahead and turn it over to Dr. Tom Mackey, who will open the floor for questions for you all.
Great. Actually, I'm still mic'd, so I'll give this to you. And then what we'd love to do now is just have a chance for a conversation. And that can be on any questions that you have for any panelists. If they're directed to a particular panelist, I just ask that you direct your question, you let us know who you would like to answer the question, or if you're just asking more generally and like to hear our different perspectives on it. I'm really thankful for being on a panel with people that offer such different perspectives than I do on this topic. And I love questions that cut across that we could each speak to, just because I think you'll get very different responses from us. So please, yeah.
I actually have a question for Dr. Mackey. On the Reach Institute tool where it gives the grades of A, B, C, that's just telling us that there is data, there's not data. Does it give a link to the data they use?
Yeah. So there's another resource that's really great for getting a better sense of what is evidence-based for children who are in child welfare. And the California Evidence-Based Clearinghouse is the name of it. And it grades the strength of the evidence in terms of whether or not it is effective, which is a slightly different question than whether or not there is evidence, right? There's a slight nuance, but it's true so the California Evidence-Based Clearinghouse is a great resource. You can look it up, just Google search it, and it should come right up. And they do that. They have both around psychotropic medications, but then also for the other psychosocial therapies that might be available for a child in foster care. So you'll also see that they do provide ratings for things like trauma-focused cognitive behavioral therapy or parent interaction therapy. They rate a bunch of different types of behavioral health and mental health treatments. And they do that all through expert consensus of prescribing clinicians and researchers. Yeah, so it's a rigorous process.
Yeah, and I know when I first heard about it, I was thinking it was just a California resource, but it actually is national. So you can go there and just kind of look at the different programs, but it's on a national level. It's not just limited to California.
Yeah, it's a great point. Yeah, that's exactly right.
Hi, I'm Teresa James. I'm the commissioner here in Kentucky of the Child Welfare System. One of the things that we are most concerned about is the high number of children who are utilizing psychotropic medications in our system right now. In fact, we are one of the leaders in the country, unfortunately. As we begin work with the University of Louisville and some of our own staff at our state Medicaid office and our medical directors, our director of behavioral health here in Kentucky to address this, one of my concerns would be how are we working with school systems and those kind of folks around the country to help prepare them for the resources and the supports that will need to be available when I believe we start making changes in psychotropic medications with children. How are other states gearing up to manage behaviors a little bit more effectively, and what do we as a state need to be considering as we move in that direction?
Yeah. It's a great question, and it really does require a multi-pronged approach. One thing I will say is states that having spoken with, this isn't evidence-based, but it is from the experience. I've spoken to state policy key informants from the 50 states in DC, so at least one person within each state, and so we learned a lot about the different strategies that they're taking, and a couple of things that I would sort of highlight from that work that we had done. One is an incremental approach to addressing psychotropic oversight. So some of these mechanisms are much more they're much more of a hard, abrasive fix. So prior authorization is a real hard response, right? Like you're just immediately cutting off the ability for prescribers to prescribe an antipsychotic medication without getting a medical necessity form. And that could have more significant impact on the system because you've put in a barrier for a population that can already have significant numbers of barriers to getting appropriate and optimal mental health services. So rather than starting with something as restrictive as prior authorization, instead looking to drug utilization review or something that happens retrospectively so that you prescribe the medication, but then you have a rigorous review process after the initial prescribing and you just have a short window within which, and states have taken a lot of different approaches for these retrospective approaches, or these approaches that happen while they're taking the medication. They have co-located regional nurses in some states. In other states, they're relying on a tiered process where they look at what's happening in their Medicaid or their child welfare data sets, and then they're having nurses do the initial review, and if it raises a safety concern, then it goes up to a child and adolescent psychiatrist who is well respected by their peers in that state and can offer peer consultations. I often recommend, thinking of it as an incremental approach over time. In some states, it started with these gentler systems, like a retrospective review, have moved over time to the more restrictive approach, like prior authorization, and you're kind of bringing the community with you that way, right? You're bringing the prescribing community with you, and they'll have learned through those consultations in the retrospective review of what the clinical rationale is for the prior authorization process. You won't get the same pushback and potentially create a really problematic barrier to necessary care in some circumstances. And the other thing I will say is that states are often doing this in concert with trying to address the provision of a trauma-informed mental and behavioral health system. So moving towards systems of care approaches that are also offering trauma-informed services that complement the efforts to be working on psychotropic medication oversight concurrently is not uncommon. There's some SANSA demonstration grants that states are finding to facilitate funding, which is the major challenge in many of these systems of care. Yeah, as you are in Kentucky, I see. Yeah, so I do think that you're exactly right that a multi-pronged approach is what's necessary, and you have to be thinking about systems of care and trauma-informed mental health services, while also, unfortunately, you have to do both. While also, because it's a lot for one system to try to handle, while also trying to address these psychotropic oversight concerns, because you could create the problem that you're speaking to as well. moving in that direction is, I think, a national movement. I mean, there have been memos, information memorandums coming out from the Administration for Children and Families, and as well as these new demonstration grants from SAMHSA and other agencies, incentivizing the movement towards trauma-informed behavioral health systems. So I think, but it is an and. I think it's very important this is in the context of providing those other supports you referenced.
Well, we just got the sign that we have about 2 more minutes, so if we have one more question, we could probably squeeze that in.
I'm curious as to why. I'm sorry, my name's Marty. I'm a foster parent as well. Her other half, maybe not her best, but anyways, why don't they go back after certain periods of time and try to see what it looks like to remove or wean the child off of these meds? And my justification for answering this is we just got a 17-year-old in our home. He'd been on meds for a long time, and my wife, the wonder of Google, she Googled his meds. 2 of them were 2 adult doses of blood pressure medicine twice a day. I take blood pressure medicine, and it feels like somebody hit me in the head with a hammer. So I'm like, this child can't be the child that he is on these medications, and he's on carbamazepine. So I'm asking myself, what can we do to help him? Well, we went to the doctor. They took him right. They didn't even argue with us about taking him off of the blood pressure medications, but they wanted to express the fact that the carbamazepine, the doctor said, mental health is just like physical health. You have to take care of it. I understood that. The boy understood it. That being said, he started weaning the boy off of the meds. He was my end result at viewing the child is that he's a typical teen now. And they thought he was, the meds are working, No, they're suppressing who he is. And my question is, why don't they go back and review that? I mean, why don't they try to at least wean them off on occasion and find out who they are?
Yeah.
And Tom, if you can give just like a 1-minute synopsis to that. And so if we have any other questions, which I'm hoping that you all do, you can definitely come up to us at the end of today's presentation. We'll be happy to answer additional questions. And I'm just going to do this, so once you, once he gives his answer, then you all can go ahead and start to pack up. But in order to be in touch with us, my name again is Cynthia Peterson. I'm with Child Welfare Information Gateway. You can reach me at cpeterson@childwelfare.gov. And if you want to be in contact with Dr. Tom Mackey, his email address is tmackey@ifh.rutgers.edu.
And so, it's a great point. And, it's interesting. I'm actually co-facilitating a listserv among child and adolescent psychiatrists with a colleague of mine, Christopher Balanci, where they're child and adolescent psychiatrists who are prescribers for children in foster care, nationally, many of them leaders within their respective states. And, they are asking the question in a flipped way, which they're saying, why aren't there standards for how you take children off these medications in the way that there are concerns around what they are being prescribed, but there are a lot of clinical concerns, of course, that arise in weaning children off of these medications, but frequently there isn't the same type of attention to what the standards clinically ought to be for weaning, for when it's appropriate to begin the process of taking them off these medications. And so I wish I had a great answer for you, but I can tell you that it's a very consonant question with what I hear leaders within child and adolescent psychiatry beginning to ask, which I find a really wonderful, as one who isn't a child and adolescent psychiatrist, I think it's wonderful that they are also bringing up this concern and thinking about about creating these consensus guidelines for weaning, for what appropriate and optimal transitioning off of the medications looks like. And they're meeting down in San Antonio at their national meeting in a month to begin some of those conversations. So I think that, I want to finish on a high note, and I do think that there is even movement within the prescribing community of child and adolescent psychiatrists to begin to address some of these concerns as well. So as we continue this conversation, I think it's so valuable for us to think of them as allies, because we all want, children to have better health, physical and mental. Right? So thank you all.
Thank you very much. Thank you.